Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of our lecture today about endometrial hyperplasia. What are the objectives today? Definition of endometrial hyperplasia, the etiology, types, pathology, behavior or malignant potential, what is the diagnosis, how can I reach the diagnosis, and lastly the treatment. Okay, let's go to the definition. Definition of endometrial hyperplasia. It is a proliferative lesion of endometrial glands and to a lesser extent endometrial stroma. So affecting endometrial glands usually more than endometrial stroma. So it is one of the proliferative lesion. And endometrial hyperplasia is a pathologic terminology. Okay? Okay. But it is very important because it is maybe a precursor to endometrial carcinoma, especially the atypical endometrial hyperplasia. So, endometrial hyperplasia is a common disorder due to exposure to exogenous or endogenous estrogen, along with relative deficiency of progesterone. So, there is prolonged exposure of estrogen. Unopposed estrogen means what? Means this estrogen not antagonized by progesterone, like in cases with anovulatory dysfunction, like PCOS, polycystic ovarian syndrome. This is one of the example of endogenous estrogen, which is produced inside the body. Okay. Also, ovarian tumor secreting estrogen, like granulosa cell tumor. This estrogen may be associated with endometrial hyperplasia. Okay. Also, exogenous estrogen may be hormone replacement therapy given to a postmenopausal lady to treat menopausal symptoms. Okay. So, the etiology is chronic exposure to estrogen or prolonged unopposed estrogen with a relative deficiency of progesterone. And as I said, the cause of this excess estrogen may be endogenous from inside the body or exogenous, like hormone replacement therapy in a postmenopausal lady. Okay. What are the risk factors? Age, with increasing age, is a risk factor for endometrial hyperplasia. Nulliparity also. So pregnancy is a protective. Nulliparity is associated with prolonged exposure to estrogen also. Obesity with peripheral conversion and excess estrogen. Obesity is high risk also. So age, nulliparity, obesity, genetic factor, diabetes mellitus, anovulatory cycles like in polycystic ovarian syndrome and women at the age of perimenopause, or is when ovulatory dysfunction happen. Okay. Also is ovarian tumor like granulosa cell tumor, which is one of the 6 core stromal tumor. HRT, hormone replacement therapy in postmenopausal lady. Immune suppression as in renal transplant cases. And infection also may be associated with endometrial hyperplasia. Blanche syndrome, hereditary non-polyposis colorectal cancer. So according to the WHO, endometrial hyperplasia classified into 2 categories. Hyperplasia without tibia, which is less dangerous to be converted to endometrial carcinoma. And the hyperplasia with a tibia was high risk to be proceed to endometrial carcinoma. So we have 2 types, hyperplasia without a tibia, hyperplasia with a tibia. What about the pathology? We have simple hyperplasia, complex hyperplasia, typical hyperplasia. So simple hyperplasia is a proliferation of both glands and stroma, but still the glandular stromal ratio is normal. Glands have some characteristics like what? Like enlarged glands, regular, occasional pseudostratification, papillary budding of epithelium into glandular lumen. Also, some gland may show cystic dilatation, and we call it cystic glandular hyperplasia. But in simple endometrial hyperplasia with this character, there is no nuclear atypia. There is no nuclear atypia. Okay? Complex hyperplasia, there is glandular proliferation, but more than stromal growth. So, glandular stromal ratio is increased. So, because proliferation of the gland is more than stromal growth. Okay? With this increased glands, looks like back-to-back appearance. Okay? So, there is no intervening stroma because of enlarged proliferative glands. Glands are enlarged, grossly irregular, with papillary budding of the epithelium into glandular lumen and pseudostratification. And here there are many mitotic figures, but no atypia. Okay? Many mitotic figure, but no atypia. The third in pathology is the atypical hyperplasia characterized by atypia, which is very important. May be simple or complex. But what is important is the atypical cells. Atypia means what? It means the presence of malignant criteria, and is characterized by bizarre shaped cells, apparent nucleoli, increased nucleus cytoplasmic ratio, increased abnormal mitotic figure, polymorphic, second wave nuclear membrane, hyperchromatosis. This is the criteria of atypia. So, as I mentioned before, WHO simplified the classification into hyperplasia without atypia and atypical hyperplasia or endometrioid intraepithelial neoplasia. So what is the malignant potential of each type? In simple hyperplasia, progression to adenocarcinoma from 1 to 2% within more than 10 years. While in complex hyperplasia, progression to adenocarcinoma 8 to 10%, also for duration after duration of 10 or more years. What about atypical hyperplasia, which is risky and dangerous, and yes, it is precancerous? Progression to adenocarcinoma up to 30%, from 20 to 30%. It's very important to know about it. Okay? Time for progression of atypical hyperplasia to carcinoma is variable. Okay? So, I can't guarantee when atypical hyperplasia will be converted to or proceeding to endometrial carcinoma. Okay, what about the diagnosis? We should take comprehensive history from each woman and do physical examination. Okay? We should concentrate on the age, also the history of the present illness, what is the menstrual history, if there is early menarche, late menopause or not, also the amount of blood loss, the pattern of bleeding, is it abnormal uterine bleeding, irregular bleeding, or post-menopausal bleeding, which happen after menopause. Okay? So, what about also the obstetric history? Because one of the risk factors is the non-liparity, as I mentioned before. So, what are the symptoms and signs, and what is the investigation needed? The symptoms include abnormal uterine bleeding, or heavy menstrual bleeding, or if coming after menopause, the bleeding is called post-menopausal bleeding. Okay, and you should mention if it is related to hormone replacement therapy or not. Also, there may be abnormal vaginal discharge, which may be foul smelling or blood stain. Abdominal cramps may happen, or other symptoms related to the underlying etiology, like if associated with functioning ovarian tumor. What are the signs? The uterus usually symmetrically enlarged. There may be other signs of underlying etiology like adnexal mass due to solid ovarian tumor, mostly maybe functional ovarian tumor. So I may have ovarian tumor like granulosa cell tumor and the endometrial hyperplasia, and the cause of endometrial hyperplasia could be related to the functioning ovarian tumor, granulosa cell tumor. So I should do pelvic examination very well to detect any uterine mass or adnexal mass and so on. What about the investigation? Ultrasound is very important, especially the transvaginal ultrasound. You should measure the endometrial thickness, and you should know the cutoff of endometrial thickness in postmenopause should be less than 4 millimeter, as guidelines say. Okay. Also, search for any abnormal mass in the endometrium, endometrial polyp, or uterine mass, or adnexal mass. Okay. Okay. Endometrial biopsy by D&C or hysteroscopic guided biopsy, or by using Pipple or Novacuret in outpatient clinic, or under anesthesia like fractional curettage, D&C, or hysteroscopic guided biopsy, and send the biopsy for histopathologic evaluation. It is very important because it is pathologic diagnosis, as I mentioned before. Okay, so transvaginal ultrasound, as I mentioned, has an important role to diagnose the second endometrium, especially the postmenopausal lady. And as I said, the cutoff in postmenopause is the endometrium thickness should be less than 4 millimeter. And if it is less than 4 millimeter, the probability of endometrial cancer is reduced to less than 1%, and thus sampling is not required. However, if persistent bleeding, even in less than 4 millimeter, you may need endometrial biopsy, because some malignancy may be associated also with this thin endometrium. So, but commonly, if endometrium is less than 4 millimeter, the possibility of endometrial hyperplasia and endometrial malignancy is very rare. So, you should reassure your patient when you see endometrial thickness less than 4 millimeter. Also, ultrasound is important to detect any other pelvic pathology, as I mentioned before, for functioning ovarian tumor, for example, or associated uterine lesion. What is the differential diagnosis for endometrial hyperplasia? I should differentiate different types of hyperplasia from each other. Also, differentiation from endometrial polyp. Sometimes the hyperplasia occur only in a polyp, in endometrial polyp. And with resection of this polyp, everything is fine because the remaining endometrium is healthy. So I should differentiate also endometrial hyperplasia from endometrial polyp. Also, I should differentiate complex hyperplasia with atypia from grade 1 endometrial carcinoma, adenocarcinoma. Also, hyperplasia from other benign conditions like normal proliferative or secretory endometrium, and everything could be fine with histopathological examination. Okay, what is the treatment? Treatment will depend on which type of endometrial hyperplasia. Is it endometrial hyperplasia without atypia or with atypia? Age of the patient is premenopause or postmenopause, desire for fertility or not. All of these are important factors. Methods of treatment, including medical or surgical like total hysterectomy, medical like hormonal therapy, either by inserting levonorgestrel releasing intrauterine system like Mirena, because here we are using the Mirena as a management for endometrial hyperplasia. Or the alternative is oral gestagen, as we will see. So I summarize the treatment in this table. Here is the age, here hyperplasia without atypia, and here is atypical hyperplasia. And here is the age, maybe reproductive age or postmenopausal age. What we are going to do? Let us start with the reproductive age. If the patient in reproductive age and diagnosed with hyperplasia without a TB. If the patient not desiring fertility, okay, I'll start estrogen therapy for 6 months, at least. The guideline said it should be at least 6 months. Using levonorgestrel releasing intrauterine system. It is the preferred method of treatment. Okay, what is the alternative? If the patient refuses to use levonorgestrel releasing intrauterine system for any reason, or if it is not available, you can go to the alternative, which is oral progestogen, medroxyprogesterone, 10 to 20 milligram per day, or norestestrone, 10 to 15 milligram per day, continuous every day till the end of 6 months. Okay? If hormonal treatment failed, there is no regression of endometrial hyperplasia, there is persistent bleeding. So, failed medical treatment, I should go to surgery by doing total hysterectomy. Okay? Okay. What if the patient desiring fertility? Gestagen therapy is given for 6 months, as I mentioned before, through Mirena or levonorgestrel releasing intrauterine system, or the alternative, which is oral progestogen, as previously mentioned. Then encourage pregnancy. So you should do management first for endometrial hyperplasia to regress endometrial hyperplasia. Also, you should know that endometrial hyperplasia is not a site suitable for implantation. So you are managing endometrial hyperplasia first for 6 months, then encourage pregnancy. Okay? What if the woman in reproductive age got atypical hyperplasia? This is very important, really. Okay, if the patient completed her family, go ahead to total hysterectomy, and you should tell the patient how big is your risk to proceed to endometrial carcinoma. So, total hysterectomy is a good choice for treatment if she completed her family. But if she not completed her family, this is a matter of question, because there is risk for atypical hyperplasia to proceed to endometrial carcinoma. But the patient wanna preserve her uterus for fertility. She wanna to be pregnant. So you should give her gestagen therapy, as mentioned before, for 6 months. Then after regression of endometrial hyperplasia, go on immediately to encourage pregnancy. Okay? But you should counsel the woman about the risks involved with conservative management of endometrial intraepithelial neoplasia. Okay? There may be coexistent malignancy. There may be progression to invasive disease, or there may be coexistent ovarian malignancy. So it's a matter of controversy. Okay? Let us go to the other age, postmenopausal age. If she has a hyperplasia without a TB, we will give her gestagen therapy for 6 months. If hormonal treatment failed, do total hysterectomy and bilateral salpingo. Okay? What if the postmenopausal lady have atypical hyperplasia? The indication for total hysterectomy is clear enough. Total hysterectomy and the bilateral salpingo is the first choice for treatment. And the approach to hysterectomy, as guidelines said, laparoscopic hysterectomy is better because of shorter hospital stay, less pain, and less post-operative complication. Okay? So, in atypical hyperplasia in postmenopausal women, total hysterectomy and bilateral salpingo should be done. Okay, what about indications for hysterectomy in endometrial hyperplasia without atypia and the woman not wanting to preserve their fertility? What is the indication for hysterectomy in such cases? If there is progression to atypical hyperplasia occurring during follow-up, if you did follow up, and we found no histological regression of hyperplasia despite 12 months of treatment. So no regression despite 12 months of treatment, the maximum duration for treatment. So you should do hysterectomy. This is the only line of treatment after failure of the medical treatment. What other indications? If there is a relapse of endometrial hyperplasia after completing progestogen therapy. If there is persistence of bleeding symptoms. And also, the last indication for hysterectomy in such cases, the woman declined to undergo endometrial surveillance, non-compliant patient with medical treatment. So, if you are not sure that this patient should do will do follow-up to be tested that the endometrial hyperplasia regressed and she may not take the treatment, so this itself is an indication to do hysterectomy. Okay, so hysterectomy for endometrial hyperplasia. What is the difference between postmenopause and the premenopause? In postmenopause, requiring surgical management for endometrial hyperplasia should be offered bilateral salpingo-oophorectomy together with total hysterectomy. Together with total hysterectomy. It's important to know. What about premenopause women? Total hysterectomy is done, but the decision to remove ovaries should be individualized. If she is high risk for ovarian malignancy or suspicious ovary, you should remove the ovary. If not, you may leave the ovary according to the age, so for the beneficial effect of the hormones produced from the ovary. Okay? And so the patient will not complain of osteoporosis, for example, and so on, because of early menopause due to oophorectomy. So this is the decision. But what is very important here, if you left the ovary, please, you should do bilateral salpingectomy. Why? Because this may reduce the risk of future ovarian malignancy. As mentioned in many studies, the source of serous tumor, ovarian epithelial tumor, may be the fimbrial end of the tube. So salpingectomy should be done. Especially, it is functionless now. If you remove the uterus, what is the aim of leaving the fallopian tube? Leaving the fallopian tube behind you may cause ovarian malignancy later on. So please do bilateral salpingectomy, even if you left the ovaries. Okay, because the patient is young and they need the hormones of the ovary. However, if there is high risk for ovarian malignancy, you should do also bilateral. Okay, I hope it is clear enough. Okay, is there any rule for hysteroscopic endometrial ablation or resection in endometrial hyperplasia? Really, endometrial ablation is not recommended according to guidelines of Royal College of Obstetrician and Gynecologists. It is not recommended. Endometrial hyperplasia is not recommended for treatment of endometrial hyperplasia because complete and persistent endometrial destruction cannot be ensured. If you did endometrial ablation, you can't be sure. Is it completely the whole endometrium is removed or not? There may be residual endometrial tissue and the endometrial carcinoma develop in this part. Second, because intrauterine adhesion formation following endometrial ablation will prevent endometrial histologic surveillance or may prevent future endometrial histologic surveillance. Because of intrauterine adhesion, you may not reach the site of suspicious area because of intrauterine adhesion during endometrial sampling. So this is another risk. That's why the guidelines recommend not to do endometrial ablation in endometrial hyperplasia. Okay, what is the management of endometrial hyperplasia in women who wishing to conceive? Disease regression should be achieved on at least one endometrial sample before women attempt to conceive. Okay? And women who wish to conceive should be referred to fertility specialists to discuss the options for attempting conception, further assessment, and appropriate treatment. Is there a rule for assisted reproduction in such a case? Yes. It may be considered. Why? Because the live birth rate is higher and it may prevent relapse compared with women who attempt natural conception. Okay, prior to assisted reproduction, regression of endometrial hyperplasia should be achieved. Why? Because this is associated with higher implantation and the clinical pregnancy rate. So, regression of endometrial hyperplasia will help successful implantation and successful outcome. Okay. Okay, let us go to the follow-up. In order to induce the regression of hyperplasia, as I said before, treatment should be for at least 6 months. And you should do endometrial surveillance with office endometrial biopsy at 6 months interval. You consider the patient free if 2 consecutive 6 monthly negative biopsies obtained. Okay, but there is some exception, like obese women with body mass index more than 35 who are treated with oral progestogen. They are at higher risk of relapse. So, they should be advised to do annual follow-up every year. Okay? And all women should be advised for follow-up if they experience the symptoms of abnormal uterine bleeding. It's clear enough. Yeah. Okay, what if the endometrial hyperplasia confined to endometrial polyp? This uterine polyp should be removed completely by hysteroscopic resection, and the rest of endometrium should be sampled. Okay? If the result of the remaining endometrium or the rest of endometrium there is no hyperplasia, so this polypectomy is considered curative, because hyperplasia happened only inside this endometrial polyp but not in the rest of endometrium. But if the surrounding endometrium show hyperplasia, it should be treated accordingly as I mentioned before. This is the end of my lecture. I hope it was clear enough. This is my books published on Amazon. Go to Amazon to find them. Textbook of Obstetrics, textbook of Gynecology, contraception handbook, multiple choice question book, and lastly the medical disorder in pregnancy book. This is my site on Amazon, and this is my site on YouTube, and this is my site on Blogspot. Thank you, everybody. My best wishes for all of you.